Welcome to this series where I'll be reviewing the 2025 ACE Consensus Statement on the algorithm for the management of adults with dyslipidemia. This is Endo in a Bite, where I break down complex concepts into bite-sized pieces you can actually remember. Let's begin. In today's episode, we're diving into the ACE guiding principles for patient-centered management of dyslipidemia, a concise but powerful framework that integrates risk assessment, lifestyle intervention, and individualized care. Our focus today is twofold. First, the foundational management principles, and second, a practical approach to risk assessment and testing that supports everyday clinical decisions. This is about applying evidence-based structure to what we already do intuitively. Evaluating ASCVD risk, tailoring therapy, and engaging patients as partners in long-term cardiovascular prevention. Let's begin with the key management principles. First, we should assess the risk of ASCVD and pancreatitis in any patient with high triglycerides, especially when triglycerides are 885 milligrams per deciliter or higher. Next, take a step back and address the underlying causes. This means evaluating dietary patterns, physical activity, lifestyle factors, comorbidities, medications, and, where applicable, genetics. Treating the lipid number without addressing the root drivers misses the bigger picture. We also need to engage patients and caregivers around diet, physical activity, and healthy lifestyle patterns, but with a realistic appreciation for access to healthy foods, affordability, and safe spaces for exercise. When pharmacotherapy is on the table, the recommendation is to use shared decision-making, balancing ASCVD risk reduction against treatment goals, preferences, and potential side effects. For populations like pregnant or lactating individuals, we're reminded to proceed cautiously. The evidence base is limited, so risk-benefit discussions are critical. Importantly, management plans should reflect individual preferences and cultural context, while also addressing medication availability, affordability, and access to care. And finally, don't underestimate the value of the conversation itself. Taking time to discuss the rationale for therapy and the need for long-term adherence improves outcomes substantially. Now, shifting to risk assessment and testing, the backbone of individualized management. AACE emphasizes a lifelong adoption of healthy lifestyle changes, including diet, exercise, stress reduction, restorative sleep, avoidance of tobacco, and maintenance of healthy body weight. And crucially, we're reminded to treat all cardiometabolic risk factors in an integrated manner, not in isolation. Who falls into the moderate to high-risk category for ASCVD events? That includes individuals with clinical ASCVD, familial hypercholesterolemia, diabetes over 40 years old or younger, if additional ASCVD risk factors are present. Also, those with HIV, metabolic syndrome, hepatic steatosis, or chronic inflammatory disease should be considered higher risk. For primary prevention, we should use a validated ASCVD risk calculator to estimate future risk and guide intervention intensity, always emphasizing concurrent lifestyle modification for everyone. The ACE framework identifies 3 categories of 10-year ASCVD risk: low risk, under 7.5%, intermediate risk, between 7.5% and 20%, and high risk, above 20%. For low-risk individuals, focus on healthy lifestyle interventions alone. For intermediate-risk patients, consider additional risk enhancers like family history, cardiometabolic disease, elevated triglycerides, or non-HDL-C and CKD, and engage in shared decision-making around treatment initiation. You can refine risk further with additional testing, such as CAC scoring, 2D or 3D carotid or femoral ultrasound, LPA, ApoB, or high-sensitivity CRP. And for high-risk individuals, pharmacotherapy is recommended to reduce ASCVD risk. Now, when it comes to tools, the guideline highlights several validated risk calculators that can be used in clinical practice. We have the Pooled Cohort Equations, or PCE 10-year risk calculator, Prevent risk calculator, Framingham risk score, SCORE2, PAHO Heart's cardiovascular risk calculator, and the Q-risk. These are the most commonly available and widely supported calculators in practice today. You don't have to use them all, but choose one and use it consistently as part of structured, shared decision-making with patients. So in summary, the ACE approach to dyslipidemia centers on 3 themes. First, comprehensive risk assessment. Second, personalized therapy grounded in shared decision-making. And third, long-term adherence supported by education and lifestyle optimization. By integrating these principles, assessing true ASCVD risk, choosing the right validated calculator, and treating the patient as a partner, we're not just managing lipids, we're improving cardiovascular outcomes across the board. So that wraps up our discussion for today. This was the introduction to the algorithm for the management of dyslipidemia, ACE 2025 Update, Part 1. Don't forget, visit easyendoprep.com to sign up for the newsletter and have all the key pearls delivered straight to your inbox. You can also explore the full board review course there for deeper learning and exam preparation. Stay consistent, and together we'll work through the ACE consensus statement on the algorithm for management of dyslipidemia, one bite at a time.